You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 15th, 2024. This week, Tirzepatide, AF screening, and an AHA preview, including VT ablation, left atrial appendage closure at the time of AF ablation, blood pressure targets, and of course, more GLP-1 agonists, this time in heart failure. But first, I want to say thank you to my friend and colleague Piotr Futima for his kind invitation in Polish hospitality in Rzeszów, Poland last weekend. I attended my 5th PQRST Congress, and it was an excellent session. PQRST is a one-day Congress. I spoke about slowing the progression of AFib. Of all the countries that I visited, Poland is my most frequent, 5 times. I love that country. It's so clean and peaceful and organized. I've run a marathon in Poland. I've had some incredibly beautiful bike adventures, and this time I had a beautiful hike in the forest south of Rzeszów. Thank you, Eric. This weekend is the AHA meeting, but I will miss it because I'm traveling to the Swiss EP meeting in Basel, Switzerland. But I will cover some of the big studies and offer a preview today. Before AHA, though, I want to talk to you about 2 studies that were recently published. First, New England Journal of Medicine published an important clinical trials in diabetes prevention with Tirzepatide in patients with obesity. It was called the SURMOUNT-1 trial. Now, we know SURMOUNT-1 has been published, but these were the 3-year results. The SURMOUNT-1 has shown to induce weight loss in patients with obesity. This week's paper from the investigators reported on 3-year safety outcomes with Tirzepatide and also its efficacy in reducing weight and delaying the progression to type 2 diabetes in patients with obesity and prediabetes. So the study had about 1,500 patients with obesity, of whom 1,000 had prediabetes. They were assigned in a 4-arm randomization to once weekly 5 milligrams, 10 milligrams, 15 milligrams, or placebo infusions. The analysis included a 176-week period, followed actually by 17 weeks off treatment. The 3 secondary endpoints of this study were body weight change, onset of type 2 diabetes during the 176 weeks, then also at 193 weeks, which what they called the extension. Patients were about 48 years old, 2/3 female, all with prediabetes. As you would have guessed it, weight loss was robust. The percent changes from baseline were 12% for 5 milligrams, 19% for 10, 20% for 15 milligrams, versus only 1% for placebo, which has been shown many times over. For the onset of type 2 diabetes, in the Tirzepatide group, it was 1.3% versus placebo, 13.3%. So the hazard ratio there was actually 0.07, so a 93% reduction in the onset of type 2 diabetes, which is obviously significant. Reversion to normal glycemia at week 176 was observed in more than 90% for the 3 doses of Tirzepatide versus 59% of those on placebo. The trial, as I said, had a 17-week off-treatment period that was placebo-controlled. And here, an additional incidence of type 2 diabetes of about 2.4% occurred equally in each of the 3 doses of the drug Tirzepatide, compared with 14% in the placebo arm. And this was concordant with a gradual and linear weight regain after discontinuation of the drug that you could see clearly on the graphs. And as expected, there were more, quote, GI events and hypoglycemia in the Tirzepatide arms. Now, the authors start their discussion by writing that A, there was a clear reduction in weight and diabetes prevention. They also noted that nearly 99% of those on Tirzepatide remain free of diabetes, and that is over 3 years. Other notables in this trial was that those who had only a small weight loss, like less than 5%, also were noted to have a reduced incidence of diabetes, and this suggests that there may be a non-weight loss cause of diabetes prevention. They cited a study that suggests that long-acting GIP receptor agonism may improve insulin sensitivity independent of weight reduction. And recall that, unlike semaglutide, Tirzepatide is a dual GLP-1 agonist and GIP agonist. So again, another positive trial for the GLP drugs. Second trial that I'd like to talk about before AHA is the GUARD-AF trial. This was an RCT to test whether AF screening in older patients, older than age 70, using a 14-day ECG monitor could identify patients with undiagnosed AFib and reduce stroke. Now recall that we already have the LOOP trial, which used an implantable loop recorder, which is a much more robust screening tool. And the LOOP trial showed that, yes, you get a ton more AFib picked up and you use more anticoagulants, but in LOOP, stroke rates were not significantly lower and bleeding rates were higher. The primary endpoint of the GUARD-AF trial was stroke, which is a good endpoint. It's not just AFib detection, it's about reducing stroke. Their primary safety endpoint was bleeding. The trial was carried out in 150 primary care sites in the U.S., and unfortunately, COVID affect patient enrollments. They enrolled what sounds like a lot of patients, nearly 12,000, but their power calculation called for enrolling 52,000 patients. The median follow-up was short, only 15 months. The age of the patient, 75, half female, and as expected, stroke rates were very low, right? 0.7% in the screening group, 0.6% in the unscreened group. Bleeding rates were also low, 1.9 and 1.1% respectively, and neither of those differences was statistically significant. In GUARD-AF, the screen group barely had more AF detected. It was only like 5% versus 3.3% in the usual care group, though oral anticoagulation use was started in 4.2% of the screen group versus 2.8% of the usual care group. So my comments, this is another negative trial for AF screening. Even though it was enhanced with older people who had stroke risk factors, the median CHA2DS2-VASc score was 3.2. This study really had no chance to show a benefit given its early termination and recruitment of only 20% of the goal number of patients. AF screening is limited by the fact that screen-detected AFib is often short in duration, and as shown by the LOOP trial and the device trials NOAA and Artesia, this low-burden, short-duration AFib is associated with very low stroke rates. Once stroke rates are that low, it's hard to lower them much more without increasing bleeding rates. I also think a 14-day ECG monitor is not enough of a window to detect AFib. If you want to have a chance to really find AFib, you need an always-on monitor, such as a loop recorder or implanted pacemaker device or defibrillator. The Stroke Stop authors may push back a little here because they used intermittent ECGs for 2 weeks, but they also enrolled nearly 30,000 people and followed them for 7 years. And the benefit that they found was very small in absolute terms and barely made significance. Now, maybe you're listening to this and having the same thought I have. What about the smartwatch? The smartwatch is basically always on. It's like a loop recorder or pacemaker. It might allow AF detection in high-risk individuals, and it's true. It does. The problems with smartwatch screening for AFib is that smartwatches were going to have more false positive, which turn out to be a huge problem when you're at scale. Watches will also pick up short-duration, low-risk AFib that will likely not have a modifiable outcome, just like the other screening trials. So, on average, I think AF screening is unlikely to ever improve heart outcomes. But the thing is, and it's true of all screening studies, within the mass of people who get screened, there may be an average effect that's not helpful, but there are going to be individuals in there that are helped, say a person with a prior stroke who develops persistent AFib. And that's good to find that. We can put that patient on anticoagulation. But in that average effect, There's also going to be people who are harmed by screening. Let's say those are misdiagnosed AFib due to APCs who then get put on anticoagulation and suffer a fatal bleeding. And that's why we do trials. We do trials to sort out average effects in large groups. Then we can discuss this with our patients and we can align the best evidence with those patients' goals. I laud the authors of GuardAF for publishing this non-significant data and for attempting to study an important and clinically relevant topic. My one-sentence summary of short-duration screened AF is they have very low stroke rates. We don't know how much AFib warrants anticoagulation. It's an area of huge clinical judgment, and it's a great place to enroll patients' values and ideas in the decision. All right, let's do a little AHA preview. I want to focus on the option trial. And I actually wrote a column on the option trial, and the title of my paper is It's the Most Worrisome Study at AHA 2024. Option will compare 2 stroke and bleeding reduction strategies after AFib ablation. One strategy is to implant the left atrial appendage closure device while you're in the left atrium at the time of AF ablation, and then, of course, stop anticoagulation after a period of time. The control arm of option is to continue the DOACs after ablation like we do now every day. My friends, I want to say something that sounds hyperbolic, but in my 30 years of medical practice, I have never been more worried about an era of overuse and potential harm from overzealous doctoring. I am so frightened about what may come from a positive option trial, a marketing push, financial incentives, and of course the gullibility of my colleagues in electrophysiology. The numbers of AF ablation worldwide is massive, and it's rising. I suspect it's in the millions. Nearly every day, I get a Google alert telling me how many billions of dollars the AF treatment market is expected to be. Now, if we add left atrial appendage closure with a foreign body to these ablations, the cost and potential risk could be massive. And every incentive to do left atrial appendage closure at the time of ablation is aligned, right? Patients will want it because the doc will tell them that they can stop anticoagulation. Hospitals will want it because it will bring in dollars. And I don't know this for sure, but I suspect that contracts will be written that will include breaks on other products if you hit a number of left atrial appendage closure devices. Doctors will like it because they will be paid more, and doing more procedures also brings status in the field of EP. And obviously the makers of the left atrial appendage closure devices will like it because they will sell more units. And in fact, already the CMS, the payers in the U.S., has created a code for simultaneous left atrial appendage closure with AF ablation. I felt so strongly about the darkness of where we are heading as a field that I wrote a column about how the option trial was designed to show positive results. I don't know the results yet, as it will be presented this weekend at AHA, but here's a brief summary of what I wrote. The first thing to consider when we're looking at studying this topic is that both strategies have as their efficacy endpoint the reduction of stroke and systemic embolism. So efficacy is stroke and embolism. Safety is bleeding. Option will test efficacy with a non-inferiority analysis. This is debatable, but it's not entirely unreasonable because left atrial appendage closure will allow patients coming off drugs. Now, the problem for the authors is that stroke rates after ablation are very low. I've looked it up and it's very low. Recall that the DOAC versus warfarin trials enrolled more than 10,000 patients per study to study non-inferiority for stroke. Option is going to enroll only 1,600 patients. So it has to increase event rates. And the way they did that is they added all-cause death to the composite stroke and systemic embolism endpoint. But we know from oodles of studies, Cabana and LAAC, that neither AF ablation nor left atrial appendage closure reduces death. LAAC showed that surgical appendage closure significantly reduced stroke, but it wasn't enough to change death. So that means they have added a noisy endpoint to each of the columns. Death is not affected by either, and it will likely be equal in both arms. And why is that important? It's important because in a non-inferiority trial, no difference in endpoints is a positive result. If you add an endpoint unaffected by either treatment arm, it makes non-inferiority easier to reach. And this was actually done in the Prevail and Protect trials, which was Watchman versus Warfarin. Here, the trialists added CV death to stroke and systemic embolism. The second problem with Option comes in their estimate of event rates and choice of non-inferiority margin. So the trialist estimated an event rate of 10% in the ablation arm and a fixed non-inferiority margin of 5%. Well, a meta-analysis of AF ablation trials in patients with heart failure, who would presumably be at higher thrombotic risk than those in Option, reported stroke rates of about 4%. Given advances in ablation technology and its ability to reduce AF burden, stroke and systemic embolism rates in Option will surely be lower than those observed in the trials of AF ablation in patients with heart failure. Therefore, the likely scenario is that the primary outcome rates will be lower than 10%, but the non-inferiority margin is fixed at 5%. So stroke and systemic embolism, even without death, are going to be lower than 10%. So if you have a non-inferiority margin of 5%, with the assumption of a 10% rate of events, if the observed primary event rate is lower than that, let's say it comes in at 5%, then a 5% non-inferiority margin allows for the active arm to be declared non-inferior, even if those patients have twice as many events. So Option could have allowed for lower than expected event rates by also testing non-inferiority with a risk ratio, but I did not find that in the rationale and design paper. We'll see what they present this weekend. Now, perhaps the biggest problem in Option is the choice to make the primary safety endpoint include non-procedural bleeding. This is glaringly bad. Patients cannot exclude procedural bleeding. Procedural bleeding is the most obvious upfront risk with left atrial appendage closure. It is the primary safety issue. So I encourage you to read my written piece on the heart.org Medscape Cardiology. Option has been designed to be positive. Then it will be spun and marketed. And I've already had a colleague show me that he's been invited to the Option celebration event at AHA. Another colleague has shown me an invite to a webinar to discuss Option results. If we start adding left atrial appendage closure to AF ablation based on this flawed trial, I think we may take the win for the most gullible cardiologist of all time. I could be wrong about this, but boy, am I worried. All right, another notable trial to look at AHA is regarding blood pressure targets. This name of this trial is BP Road, and is a big RCT in China. It enrolls 12,000 patients with diabetes, and it's studying blood pressure targets less than 120 versus less than 140 millimeters of mercury. The primary endpoint is major adverse cardiac outcomes of MI, stroke, heart failure, and CV death. The follow-up is 5 years, and they've designed this trial to find a 20% reduction in the primary outcome. And if this sounds familiar, it should. It is similar to the ACCORD trial, 2010, New England Journal of Medicine. In ACCORD, a hazard ratio for the intensive arm was 0.88. That 12% reduction did not reach statistical significance, but also in ACCORD, which was type 2 diabetes, serious adverse events were nearly threefold higher in the intensive blood pressure arm. So if the BP Road trial is positive for the intensive arm, we should be listening for why the authors think it is so. Why is it different than ACCORD? I mean, one reason could be that things change, right? Patients with type 2 diabetes nowadays may be more robust than they were 24 years ago. There also may be a higher rate of comorbidities now that favor more invasive blood pressure. But it is interesting if this trial comes back positive, how it will be discussed in relation to the ACCORD trial. Another trial that I'll be looking at is called the SUMMIT trial. This is GLP-1 agonist. And what would a major medical meeting be without another positive GLP-1A trial? Now, you may think I'm giving away the results, but no, I'm not, because on August 1st, Lilly announced in a press release that Tirzepatide reduced the risk of heart failure outcomes, heart failure hospitalizations, or CV death by 38% versus placebo. Now, SUMMIT enrolled a common type of patient we see here in the U.S., BMI greater than 30, and an admission for heart failure with preserved ejection fraction. We already know from the press release that the combined endpoint is massively positive in relative risk terms. At AHA, we will learn what are the absolute risk reductions. We will learn whether there was a reduction in CV death. And I make the distinction because I've said many times, the endpoint of hospitalization for heart failure can be a biased endpoint, especially in an unblinded trial. And make no mistake, GLP-1A trials are unblinded because it's very easy for patients and likely clinicians to know that someone is on a GLP-1 agonist drug. The other thing I would push my friend, the PI, Dr. Milton Packer, on is what proportion of total hospitalizations is hospitalizations for heart failure. Now remember, heart failure hospitalizations is only a good endpoint if it represents a solid chunk of hospitalizations. This has been a problem for the HFpEF trials because HFpEF patients often have multiple morbidities and therefore multiple reasons to be hospitalized. For instance, recall that in the Emperor Preserve trial of empagliflozin versus placebo in HFpEF, the endpoint of hospitalizations for heart failure represented only about 10 to 15% of total hospitalizations. And of course, what patient cares why they're hospitalized? And of course, this is different than HFrEF. The old ACE inhibitor, carvedilol trials, RALs, hospitalizations there were mostly always for heart failure. But with HFpEF, it's a multimorbid condition. So these endpoints are important because GLP-1 drugs stand to bankrupt our healthcare system. And if we are to use these drugs, they ought to be for patients who stand to derive substantial benefit in hard outcomes, such as death or CV death or some unbiased outcome. If the drugs only reduce one of many causes of hospitalization, then it's hard to justify the cost. Finally, the SUMMIT trial will also have a co-primary endpoint of quality of life as measured by the KCCQ. This is a totally unfair endpoint because GLP-1 drugs cause unblinding, and that renders patient-reported subjective endpoints about useless. Another trial in EP is VT ablation, and this is done by Canadians, and Canadians are great for doing these types of trial. Professor John Sapp leads the VANISH2 trial of where post-MI patients who had VT are randomized to catheter ablation or antiarrhythmic drugs. And it's a common question in EP. The primary endpoint of the VANISH2 trial will be death, appropriate ICD shock, VT storm, and a treated sustained VT below the ICD detection level. Now, Dr. Sapp also led the VANISH1 trial, and it studied post-MI patients who had VT that were already on antiarrhythmic drugs. And in VANISH1, one arm had VT ablation and the other arm had escalation of antiarrhythmic drugs. VANISH1 trial was barely positive, and most of the benefit was seen in patients on amiodarone at baseline. In other words, if you were on sotalol and changed to amiodarone, the Kaplan-Meier curves were identical. Recurrent VT drove the benefit, and death rates were similar in VANISH1. I think VANISH2 is a more relevant question these days. What to do with de novo VT? Do you start drugs or ablate? And so this is a good trial on an important topic. The biggest problem with VT trials, the VANISH trials included, is external validity. That is, how to generalize the results from a trial done totally in expert centers to standard EP practices. Now, I've visited Canada numerous times, and ablation procedures there are done in extremely exclusive, high-volume city centers. I mean, one province has 2 ablation centers in the whole province, and this means that Canadians are ablated by highly experienced operators in highly experienced centers because there are so few ablation centers. Now, in the U.S., it's totally different. There's EP centers everywhere. Most EP practices like mine, for instance, do 10 times more AFib ablation than any other ablation. And AFib ablation, truth be told, can make you dumb. It's anatomic and it's robotic. VT ablation requires serious skill in EP. It's also hazardous. These patients are sicker. You're in their ventricle. So if VANISH2 comes out positive, similar to VANISH1, the challenge for patients and clinicians using this evidence is whether low-volume VT ablaters, who mostly do PVIs or Watchmans, can duplicate results found in centers of excellence in the trial. All right, next one is clear synergy. Now, last week, I covered the results of Clear Synergy trial of colchicine after acute MI. Colchicine did not improve outcomes, and this was a surprising finding to some because 2 previous trials in coronary disease, Colcot and Lodoco, were positive for colchicine. Well, the Clear Synergy trial was actually a 2x2 factorial design, and one arm included spironolactone. At TCT, we learned the negative colchicine data, and at AHA, we'll learn the results of the spironolactone arm. I think a lot of spironolactone. In fact, the RALS trial of spironolactone versus placebo in HFrEF was one of the most positive trials in all of cardiology. You should go look at this trial. It is an amazing result, huge effect size in death. So spironolactone is a really important component in HFrEF care. And if you look at the Americas portion of the TopCat trial with HFpEF, spironolactone also probably provides a benefit in patients with heart failure and preserved ejection fraction. But the problem with post-MI patients who have PCI is that they have really low outcomes. I mean, that's good news, right? PCI has transformed post-MI care such that even beta blockers don't help anymore. Now, I don't know the results of Clear Synergy, a spironolactone arm, but it seems unlikely to me that spironolactone would improve outcomes. Not because spironolactone is an ineffective drug, but rather it's hard to do much more for a group of patients who are doing so well. All right. Last week, I went kind of long, so I'm going to stop here. Even though I'm heading to Switzerland for the Swiss CP meeting, and I'm going to speak on choosing patients for PCI, I'm going to keep an eye on AHA and do some reporting on it. There are many, many good studies coming out of AHA, including a number of non-statin lipid-lowering drugs. This is a huge space these days. These are hard-to-pronounce drugs like zerlasiran and movalpin and obicetrapib. Most of these are early phase 2 studies. Press releases have noted positive results on lipids. And I mention these drugs because a lot of it is happening in the lipoprotein(a) space. The problem with all of these drugs is obviously how much, if any, reduction in clinical outcomes we get, and at, of course, what cost, and we're going to have to wait for that. The other problem with these lipid-lowering drugs is it's just like post-MI care, right? The statin drugs have set a high bar. Here are inexpensive drugs that reduce clinical outcomes by 20% with very little side effects, and so we have a really high bar for non-statin lipid-lowering drugs. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write me a review. If you don't agree with something that I said, you can make a comment on the website, send me an email. I always learn from these comments. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.